Thank you, Dr. Wright, and thank you for your perseverance. I know it's been a long day. It's been exciting, a lot of information to take in. I'm going to sort of present a little different perspective. I'm going to have a step back and look at where we've come from, where we're at today, and where we're going. And what I would like to do is sort of keep my presentation short so that we can encourage discussion about where we should be going. So let me start. The exposome, again, the definition, the measure of all exposures of an individual in a lifetime and how those exposures relate to health, that's pretty standard. Again, Christopher Wilde, going back to 2005. Sort of as an introduction in terms of my work in what we call the public health, or my team's work in the public health exposome. We started, it must have been around 2010. And again, we had, I'm director of our Health Disparities Research Center. We got a supplemental award from the Environmental Protection Agency to establish an environmental corps. And through that, I invited Dr. Darrell Hood. We have a urban planner, GIS person, Dr. Wansu Im, Dr. Armandla Ramesh, who's another toxicologist, to help me develop that, because I have no idea about, at that time, environmental health and what that entailed. So with that, we, again, I had this idea, and I was talking to Dr. Hood, and he said, Paul, that's the exposome. And he said, look at the NIEHS strategic plan. I think it was 2010 strategic plan. So I looked at it, and I got really excited. I said, this is exactly what we should focus on through this new environmental corps. And we were fortunate to get funding. And one of the things I learned, again, right away, is that there's not an ontology. There's no standard way of talking about the environmental corps or the external environment. And so, again, part of our initial discussions were, how do we do that? And again, the whole issue in terms of, where do we begin? How do we measure exposures? And so there were a number of things that we talked about in terms of the sources of exposure and what we would need to, what that would need to entail. And that includes both chemical exposures, and we sort of identified that as a natural and built environment, chemicals out there, and the non-chemical exposures, which were more in the social determinants and sort of policy determinants arenas. And then the second thing that we discussed were like exposure pathways. And again, how do we think about the exposure? And so the part of this was looking at the, again, beginning to see things like how are these chemicals or non-chemical stressors absorbed into the body? What are the mechanisms and pathways through which they operate to have an impact on health? And again, at a population level, then health disparities. And then what are the characteristics of those exposures? Again, the duration, the concentration, the frequency, those sorts of things. And as we did that, again, there were a lot of things that we began to discuss, is how do we capture that information? And as we looked at different sources of data, we found that there's different geographical units. Again, there's point data, there's sort of spatial data that are geographic units, it's census tract, zip codes, counties, all of that. And then on the other side, in terms of the internal environment, is, how do you begin to capture the impact that they're having inside of the body, and that is at the organ or cell or subcellular levels. And then the big issue is, how do we align those data? How do we align external exposures with the internal effects that it's having on the body, and how that leads to, again, poor health outcomes and then population level disparities? So we began to discuss how can we standardize data, what are the standardized units we use, and how do we combine those units, and then how do we create crosswalks between different units? And I'll give you an example. For spatial data, again, some of the data is captured at, say, a zip code level or a census tract level, and other data are captured at a county level. How do you begin to merge those so that you can analyze them and work together, harmonize those data? And so, again, those are some of the issues that we started struggling with. We also had to address, again, how are we going to store the data? Again, in terms of what type of database. Is it going to be a flat database? Is it going to be a relational database? How do we normalize it? You know, who are the end users? How often are we going to update the data? How do we document it? You know, how do we allow access to the data? These are all questions as we begin to think about capturing the data, how we would do that. And so we started by, again, creating an ontology of the external environment. And we identified initially 4 domains, the natural, built, the social, and the policy domains of external environment. And the natural environment was, we sort of, again, had subcategories of air, water, or land. And we use land rather than soil because land also captures sort of land cover, land use types of variables. We defined the built environment as places you live, work, play, and pray. We identified or defined the social environment sort of as social demographic characteristics, social or economic and political variables as well. And we defined the policy domain as federal, state, and local laws and regulations. About 3 or 4 years later, we added a 5th domain we called health and healthcare. And we did that because these data didn't really fit neatly into the other categories. And so health data is sort of personal health. It's morbidity, mortality, behaviors, and healthcare was sort of the healthcare access types of data. Again, number of providers, medically underserved areas, hospitals, those sorts of things, costs, all of that we stuck under healthcare. And as we began to do that, we recognized that, you know, our initial team didn't have all the expertise that was needed to really to talk about this new sort of external exposome, or what we've sort of termed as the public health exposome. And so we began to develop out our team by inviting people from other disciplines. We had clinicians, physicians and nurses. We had basic scientists, toxicologists. We had social and behavioral people, policy people, public health. We have computer science, earth science, domain science, data science. I mean, it was just like, you know, as we began to try to work with these data, we recognized that, again, there were just limits to our own training in our own disciplines, and we needed to expand that. And so we developed what we call our public health exposome data. And we're now up to 5.0, and the first public health exposome data set, 1.0, I think was about 600 variables. Our public health exposome 2.0, I think was about 12,000 variables. 3.0 was 25, so it almost doubled. 4.0 was 52,000, and now 5.0 that we're currently developing out is now over 72,000 variables. And again, some of the limits of data, and this is all publicly available data, we standardized it. We decided that the standardized spatial unit would be county and the standardized temporal unit would be annual, although we have data for smaller units, both spatially and temporally. The data, some of the limits of the data is that electronic data is really only available from 2000 on, with the exception of census data. And so going back, you can find data that are, you know, printed, but we didn't have time or resources to try to get those data, you know, to convert those into electronic data. So we really started our data set at 2000. We're continually updating and adding new data. We have now a metadata dictionary, and I'll just sort of talk about that in a second. And we also have begun providing access to our data this, again, that what's now 72,000 variables through data use agreements. So just to give you an example of, again, how we structured the metadata, we have the domain, again, that's the social policy, you know, the natural built social policy environments. That's sort of what we call the domains. The subdomains, again, for the, again, air, water, land, that's sort of the subdomain. We have categories and subcategories. We have variable names, variable descriptions. We have geographical units, dates, et cetera, all, again, for every variable in our data set. And then we also have, you know, the source of the data. We have a URL link to the data, so if we need to go back, we can click on it. And we provide notes on who entered it and those sorts of things. So again, this is just for air, an example, the natural air quality, AQI, CO data, variable name, again, description of the data, the geographic unit, the space of the number, again, it just goes on. And so we have this type of, in our metadata, we have this data for all 72,000 variables. The other thing, though, that, again, that we've done in recent years is now we also have added a number of years of PM 2.5 data. We have, I think it's 12 years of particulate matter 2.5 and heat metrics data. Now the PM 2.5 data, we had, again, we contracted out, it's common, the database were developed using both the air monitoring station and satellite data. And so, again, it reflects that because, again, there are some limitations, particularly with the satellite data. And again, what we ended up with is a data set that is just 1 day, and it was for 12 southeastern states. And so we have 3-kilometer grid cells of PM 2.5 over 12 southeastern states times 365 days in a year, and extra, I guess, for leap year, over like 12 years. So we're getting into these really large data sets. The heat metrics data that we have is 1 kilometer. It's daily 1 kilometer data for 12 southeastern states times 365 times 12 years. So these are now becoming huge data sets. We've got to figure out how we're going to store them, how we're going to be able to use them in some of the data analyses. And one of our colleagues, Dr. Michael Langston, is a professor in computer science and engineering at University of Tennessee, and he has access to all the computers, the big iron over at Oak Ridge. And so when we need the data combined and analyzed and things, he handles that for us. And the reason we did this in terms of the data is that we wanted to link it to the Southern Community Cohort Study, which is a cohort of 85,000 adults that I think they were recruited at age 40 or above, and they've been followed since, again, for over 12 years, probably about 15 years now. It's really a very exciting data set because they've got 4 survey waves that they've conducted with them with just extensive histories, nutrition histories, exercise histories, pharmacy. I mean, it's just family medical histories, personal, it's like just tons of data. But what they've been able to do is they've also linked it to other data sets, including Medicare and Medicaid, Medicare Parts A, B, C, and D, Medicaid data, hospital discharge data, state cancer registry data, death index files. And so it represents just a huge amount of health data. The one thing they didn't do, and I can't really figure out why, is they didn't link it to EHR data. And these are the 85,000 people in the study were recruited from community health centers or federally qualified health centers in these 12 southeastern states. And so it's it's a very low-income population or sample, and it's about 60% African American. And so it's just a very extremely rich data set. And so what we did, we couldn't get any personal health information and geographic indicators, zip code and all that is considered PHI. And so that was really sort of a challenge. But what we did is we used the 3-kilometer grid cells, we linked that to the residential histories, addresses of people in the cohort, and we used that as a proxy for where they lived, and then we were able to link that to all the other, again, to the counties in which, you know, we had all these other data. And so you have to sort of be creative, again, in terms of the analyses, again, from the beginning, we sort of have used big data analyses, these computational methods that really looks for patterns in the data. It's not hypothesis driven, and we've had problems getting funded because of that. A lot of the epidemiologists on these study sections don't like that. That's not real science, they say. But we've continued to use that in our work to, again, to mine all these data, to find out what are those loose associations, and then we take that and we can confirm them with other more traditional statistics. And so, again, we've also utilized GIS from the beginning. Dr. M was GIS really expert. So the visualization has always been part of what we do and how we analyze our data. So, again, we've started, and this is sort of a new announcement. We were the Research Center on Health Disparities, Equity, and the Exposome. Recently changed that, and now I've got the authorization to move ahead from our president to establish the Institute on Health Disparities, Equity, and the Exposome at Meharry. And so we are now moving forward with additional support, institutional support in doing that. Again, the other thing I'd like to say is since the very beginning, since the onset of when we began to develop our EPA supplement, we've had a weekly, what we call our Exposome working group meeting, and it meets every Tuesday at 3 o'clock Central Time. And, you know, we have, again, a distribution list probably of 50 or 60 people that, you know, have expressed their interest in being part of our working group. And we'll get maybe 15 to 20 people any particular week. But I would like to, for people that are interested in perhaps participating in that working group, just to extend an invitation, if you send an email to me, and I've got it on, I think, the next slide, we'll put you on that distribution list, and it really invites you to participate. And what we do through that meeting is we again discuss, and I think the mapping and things like that are issues that will make it onto our agenda. We also work on papers together. People have an opportunity if they're writing grants. We have colleagues across, you know, very senior members in many different disciplines that you may, you know, want to invite to be part of that or can provide input into developing those applications. So we write grants, we write papers together, we discuss issues, and then more recently, I'm now also a multiple PI on the NIH AIM Ahead program, Artificial Intelligence Machine Learning, and there's a lot of new resources and opportunities that really are available through that for people that are interested in AI, ML, and how we can integrate that into research. And so that's another resource that I would like to bring to the table and really begin to apply to sort of the big data that we've accumulated. So I think future directions, and I'll go ahead and just sort of say these are some of the things that we're been thinking about in terms of, you know, linking, how do we link PhD data to other cohorts. And through the AIM Ahead, I've also come into contact with the OCHIN database. OCHIN is a network, is a practice-based research network of about 1,000 federally qualified health centers across the country that use EPIC, EHR. And again, it's I don't know how many years offhand it is, but it's multiple years of EHR data that they are making available through the AIM Ahead opportunity or program. So these are some things that I think are really exciting opportunities. Would like to sort of, you know, have an opportunity to get input and maybe see how you can also, you know, what ideas you have of how we can move this sort of agenda forward. And the last thing I just wanted to say, and I was going to ask our previous speaker, how do we align external measures of exposure with internal effects? And again, I think that issue was raised earlier sort of by, or talked about by Dr. Wright, but it's one of the things that is perplexing because, you know, again, there are many different things that we have to consider in terms of the alignment. It's not just, you know, again, how we've been able, for instance, one study that we're doing is on maternal mortality, led by Dr. Maeve Wallace down at Tulane. And what we've been able to do is take our PM and heat data and align it to trimesters of women who over, I don't know, 6 or 7 years who died, you know, during childbirth or within a year after. And again, so we're able to align the data for everybody in there, all of our the PM data, because it's daily, and we can identify that by which trimester they're in. So that's the sort of thing we can align data. That's sort of an easy, you know, easy way to do it. But as we look at other, you know, other effects that, you know, there may be a lag in terms of, you know, multiple years. How do we really align, temporally and spatially align the effects of the external exposure on sort of the internal exposome? So that, again, I'm going to stop here, and I'd like to really have this as an opportunity for us to talk about some of these things or other ideas or suggestions that you may have. So